Let me introduce myself. My name is David Ross. I am the director and fortunate to be the director of the Mental Health and Recovery Board here in Ashland County. I always like to read a little bit about what the board is because I don't want to assume folks know what that is. The board is basically made up of 18 citizen volunteers that are residents of Ashland County. Board members ensure that an accessible, responsive, an effective system of mental health and substance use services is available to Ashland County residents. Again, this is an important element. These are Ashland County residents looking out for Ashland County residents. The board does this through contracts with our certified behavioral health partner agencies, all of which have exhibits that you can visit. And I'm going to encourage you whenever we have a break, certainly at lunch, please visit our exhibitors as well as our co-sponsor, Disability Rights Ohio. I always like to give a shout out to Jerry Strasbaugh with Appleseed Community Mental Health Center, Rick Ford at Acada, who true to form, Rick is back at the office because of some staffing shortages. He's got to make sure that clients are being seen, but we appreciate Rick, and then Cheryl Villegas at Catholic Charities. Just great people, great staff. We can't do the good work. The board can't do the good work without good providers. We need each other, and we're just thankful. These are long-standing relationships that we don't take for granted. So thank you all, you and your staff, for being here today. The purpose of the conference, all of you hopefully picked up a conference catalog when you came in. If you missed that, they're out at the registration table. It tells a little bit about the history of the conference. We'll have some slides over lunch that go in that a bit more, but even better than the history that's in your catalog or the slides is to talk to somebody who was there at the beginning. And we are very blessed to have Mr. Steve Stone in the audience. I won't point him out to you, but those of you who know Mr. Stone is, you can talk to Steve about how this all got started when him and Pat started talking about a conference that was a little different than the other conferences that were out there. So thank you, Steve, for joining us. Your vision lives on. For as long as I'm around, as long as the board keeps me, we're going to keep that vision going. Speaking of that vision, what is it? People always ask, what's so different about the Ashland County Mental Health and Recovery Board? Well, Steve, under his guidance and leadership, we were able to produce a document, Our Human Community. It's on our back table, so that back corner, pick it up, read a little bit. And I even brought the executive summary version. Some people have told me that the full version's a little bit too much, but we do have a more robust version of the document if you're so inclined. But please pick that up if you want to know more about what the Mental Health and Recovery Board is, because a conference like this just can't happen without some undergirding, some foundational principles. And I think it'll make sense once you start to read that document about why we would even have a conference like the RSVP conference. Historically, this conference was built with Pat Risser at the table, and Trish, his widow, is with us today, and she was out the registration desk. The voice of the person that is receiving or has received services in our system is critical when we do this conference. So I know we have several folks that were here from Pathways, our local peer center, that helped us with the planning of the conference. I would like to recognize those folks. If you don't mind waving a hand if you're in the room. We have a few folks at that table. Thank you for participating. So their voice in the selection of speakers and topics is really important to us. We always have a good mix. We have, and that's intentional. We're trying to get folks that might be in recovery themselves, but also some of the professional folks in the different disciplines. So thank you for your voice. You continue to have an important voice when we plan for this conference. I have to keep us on track, so I'll talk fast. I hope that's okay with folks. One of the things that we're doing differently, in addition to the Zoom option, is the CEUs. We're using a program called CE Go. Ashley Ackerman is behind the scenes. Ashley, oh, she took her video down, but she really is, she exists. She is the point person. Thank you, Ashley. I should call her Dr. Ackerman since she's a PhD now, but Dr. Ackerman is behind the scenes making sure your CE Go and your CEU experience goes well. There's information in the catalog about your dashboard, and that's for you all in the room as well as you folks that are online. And I forgot to tell some of the speakers, that little camera there, that's our link to the outside Zoom world. So try not to wander, Rob. You can't do that, Rob. Don't do that. So we do have to kind of stay right here so the folks can see us. I should have mentioned that. So if you have any issues with the evaluation, or you have questions about what's in the catalog about how to use your dashboard, it's pretty intuitive. And I say that as somebody who struggles with some of the technology. I was able to click on it, and pretty much as soon as the sessions are over, you can go on and do the evaluation. And then I think you automatically get a certificate, et cetera, for those of you that are interested in that option. So that's a little bit different, but take advantage of it. It seems really straightforward. And know too that your evaluations, we look at that. The planning committee, we will evaluate what you all say about the conference, and we always try to make improvements. And the speakers always are interested in what you have to say. So please be honest when you do those evaluations. We do have Mr. Wypond here with us live. So that means he's willing to sign books, which are on the back table. We're selling those. We're even beating Amazon on those, Rob. $20 we're selling those. So there's some also other ways you can get the book, and there's information on the table about that if like you'd like an audio version, et cetera. Excuse me for a cough. So please, when Rob's, now you can't ask him when he's speaking to sign anything, but when he's not busy eating or speaking, I think Rob will try to make himself available for a selfie or a sign. So just, he's right here. Rob, well, you're going to see Rob after Dr. Moncrieff talks. So this is what Rob looks like. And we got a big picture of him back there on the table as well. We do have a lineup for you. And we're very excited about the folks that we have. Every year we say this, but every year we feel like we have to top ourselves. And I think we did it again this year. Before I jump in and introduce our board chair, Nancy Udoff, I did want to give a shout out to Erica here at the university and her staff, because this was our first time, and the college hasn't done a ton of these hybrid conferences. I appreciate Erica and her staff. And if you have any needs with the food as we go on, just let me know, and we will address that. But thank you very much for all your support and the tech support as we've been getting this set up. With that said, I don't want to take any more time because our speakers are ready. I think Dr. Moncrieff is ready. So I would like to introduce Dr. Moncrieff, but I want to save that privilege. I wanted to do it, but I do, have somebody else that I really wanted you to meet and allow her to introduce Dr. Moncrieff, and that is the chair of the Mental Health and Recovery Board. Nancy Udoff, some of you know, most of you know if you're from Ashland County, retired professor here at the University in social work, but Nancy is a current board chair, and I couldn't have a better board chair. She has been a wonderful support to me, an encouragement, and she starts a lot of our board meetings with words of wisdom, and they are very, very good words of wisdom, so we appreciate that. But Nancy, if you wouldn't mind introducing Dr. Moncrieff, and if we could welcome Nancy, that'd be nice.
Thank you, David. I'm going to try to get through this without coughing, if I can. I have the crud, whatever it is that's going on, not COVID. Tested negative twice. So I am very pleased to welcome you to this conference. This conference, I think, is very meaningful and has been very meaningful to our community as a whole. And I think we all learn a lot every year at this conference. And we are so pleased this year to have Dr. Joanna Moncrieff join us from London, I believe. And Dr. Moncrieff, I think it's probably maybe 2 o'clock in the afternoon there?
Indeed, 2 o'clock, yes.
Okay, 2 o'clock in the afternoon. So we appreciate her taking time out of her busy day to join us for this conference. I want to tell you a little bit about her because I think her background you'll find very fascinating in terms of this conference. So let me just share with you a little bit about who she is. So Dr. Moncrieff studied medicine at the University of Newcastle upon Tyne, and then trained in psychiatry in London and in the southeast of England in the 1990s. But during her undergraduate years, which I think is kind of interesting, she conducted research. Now, I don't know that most undergraduates necessarily conduct research, but she did, on parents' fears about substance misuse. And during the course of her psychiatry training, she worked on a trial investigating the use of the drug naltrexone in people with alcohol problems. She also investigated the prevalence of previous sexual abuse among people attending alcohol treatment services. Dr. Moncrieff also took up her current post then that she has now in 2001, and for 10 years was a consultant for a psychiatric rehabilitation inpatient unit, helping people with severe and long-lasting mental health problems. But for the last 3 years, she's been based in various community mental health services in Northeast London. Dr. Moncrieff also teaches and conducts research at University College in London. Dr. Moncrieff is one of the founding members and co-chairperson of the Critical Psychiatry Network. The Critical Psychiatry Network consists of a group of physicians from around the world who are skeptical of the idea that mental disorders are simply brain diseases, and of the dominance of the pharmaceutical industry. So I think she's going to have some very interesting things to say to us. So you can see her there on the screen, and I'd like to introduce you to Dr. Moncrieff. Thank you for coming.
Thank you, Nancy. Thank you. Can everyone hear me all right? Is that? Yeah, I'll assume you can. Thank you. That was a very comprehensive introduction and reminds me that my first area of interest and experience was in substance misuse. And what I suppose I've been doing subsequently is trying to take some of the principles that have been derived from our study of the use of recreational drugs and their effects on the body, and apply them to the drugs that we use to treat people with mental health problems. So, and just to say, as well as doing research, I still work in the National Health Service in the United Kingdom, in London, currently in a community mental health team. So,
Dr. Moncrieff, I'm sorry, it's David. The volume's a little low on this end. I didn't know, Erica, if we had it all the way up or if Dr. Moncrieff could talk just a little bit. I wasn't sure.
Does it help if I put my volume up?
Hold on just a second.
Does that help?
Oh, we were low in the room. Did you do another test?
So is that better? Can people hear me better now?
But now.
Yes. Okay, lovely. All right, thanks. Again, just shout if there's a problem. Okay, so I'm going to talk to you today about understanding psychiatric drugs, the drugs we use for mental health problems, in a different way, and thinking about what that means for taking a recovery-oriented approach to helping people with mental health problems. So I'm going to share my screen now. Share my screen and show you my slides. And it's rather irritating presentation of that one, but it doesn't happen with each slide. Okay. Right. So first of all, I'm sure that all of you who work in the mental health sector will be aware that there are sharply differing views about the benefits and value of psychiatric drugs. So there are those who believe that they are miracle cures that have transformed mental health care from essentially a custodial activity to a therapeutic activity. And there are those who feel that the drugs are evil and harmful, particularly people who have taken them and been forced to take them against their will. These are some quotes from people about the experience of taking antipsychotics. People have described it as being like a drug prison or a living hell, for example. And the picture is from a protest against the use of against forced drug treatment. So what I want to say, it can be summarized really in this sentence, and I'm just showing you my books for in case you wanted to follow it up further, but there are also plenty of articles you can download for free on the internet. So my basic point is that some psychiatric drugs can be useful in some situations, but we fundamentally misunderstand what they do. And because of that, we are not using them carefully enough or sensibly enough. So the basic misconception is this: it's the idea that these drugs work by correcting an underlying biological abnormality, that they have what John Davis called in 1980 a normalizing effect. Usually that, or often that underlying abnormality has been thought to consist of a chemical imbalance, of an abnormality of one of the brain chemicals. Sometimes it's thought to consist of abnormal circuitry or networks or neurogenesis. It doesn't really matter what the abnormality is. The point is that the idea is that the drugs are rectifying something, some underlying process. And this view has been very widely disseminated by the pharmaceutical industry. Here is an advertisement for the antipsychotic zisprazidone, Geodon, showing a woman sitting in this very nice balanced position. But the same message has also been put out there by psychiatric organizations and other organizations that provide information for the public. And this idea is what I have called in a lot of my writing the disease-centered model of drug action. So it's the idea that the therapeutic effects of a drug arise from its effects on the biological mechanisms that produce symptoms. Now, note, it doesn't necessarily mean the drug is targeting the ultimate cause of the disease, just the mechanisms that produce symptoms. Most drugs in general medicine, can be understood in this way. So your inhaler for wheezing, for asthma, is something that doesn't target the cause of asthma, but it is a treatment for asthma because it reverses the constriction of the airways that produces the symptom of wheezing. It relaxes the airways. Now, there's another way of understanding what drugs might be doing when we give them to people with mental health problems, and particularly the drugs that we currently prescribe. And this is the idea that what they are doing is, rather than correcting an underlying abnormality, is creating an abnormal, or to be a bit less sort of controversial, altered state of the brain. And by altering the normal state of the brain, they produce changes to mental activity, so changes to thoughts, feelings, and behaviors. And when these changes are superimposed on underlying difficulties, underlying unwanted feelings and behaviors that we might call symptoms, they may be experienced as preferable. And examples of this way of thinking might be the use of alcohol for social anxiety disorder. We know that the mental alterations produced by alcohol include the lessening of social inhibitions. And when that is superimposed on a state of social anxiety, it can be helpful. We also have a phrase in English, we talk about drowning your sorrows with alcohol. And again, that's a recognition that the altered state produced by alcohol, when it's superimposed on underlying feelings of distress and low mood, will temporarily replace those feelings. Another example that I think is helpful just to understand the distinction between these ways of thinking is to think about the effect of painkillers. So painkillers like paracetamol or aspirin are drugs that do not have prominent psychoactive effects. They don't change our mental states. They target, obviously they don't target the cause of a disorder, but they target pain mechanisms, and that's how they reduce pain. So they work in that disease-centered way. Now, opiate drugs also have some disease-centered action. They target pain conduction and slow down pain conduction messages, impulses. But opiates, unlike aspirin and paracetamol, do have psychoactive effects. They do change one's normal mental state and behavior. And one of the changes they produce is they induce a state of emotional indifference. So people who have taken opiates for pain will often say that they don't, that they still have some pain, but they don't care about it anymore. And that aspect of their effects is what I would call a drug-centered effect. So the drug-centered model highlights the fact that the drugs that we prescribe for mental health problems are what we might call psychoactive substances. That is, they are substances that enter the brain and change the normal state of the brain, and by doing so, change normal emotions and thoughts and behaviors. There are often linked physical alterations. So if we think about a sedative drug like Valium or diazepam, it produces both physical and mental sedation. And these drugs that alter people's mental states can make people feel good. They can cause euphoria. They can be pleasant to take, nice and relaxing or stimulating. But some of them are unpleasant, generally unpleasant to take. So antipsychotics, most people do not find pleasant to take. And I think this is really a fundamental misunderstanding. We've generally associated drugs that change the brain and change normal mental states with producing pleasant experiences, and therefore having and therefore becoming the target of recreational use or misuse. But that's not necessarily the case. There are plenty of drugs that produce a mental state that most people find unpleasant. And of course, there is great individual variation in the sorts of drug-induced states that people enjoy. Some people I've known people who have enjoyed the effects of haloperidol, for example, whereas most people find that a very unpleasant drug. So the drug-centered model also really emphasizes that drugs are changing the normal state of the brain and indeed of the body. And these changes, there are changes that occur immediately after the drug is taken. There are different sorts of changes that occur when a drug is taken continuously on a daily basis for a period of weeks or months. There are changes that occur when after a drug has been taken for some time and when the drug is stopped. So that's withdrawal effects. And then some drugs have what psychopharmacologist David Healy has called legacy effects. I think that's a good term. That's why I'm using it. These are persistent effects that persist after the drug has been reduced or stopped. And examples would be tardive dyskinesia that can be induced by long-term antipsychotic treatment, and also persistent withdrawal effects and persistent sexual dysfunction, which are recently being revealed to be consequences of long-term antidepressant treatment in some people. So just a little bit of history about these different ways of thinking about psychiatric drugs. Prior to the 1950s, drugs were generally understood as acting according to that drug-centered model of drug action. And this is an advertisement for amphetamine, and it's clearly highlighting its stimulant properties. It's showing how it's going to make you smart and confident and energetic. This is an advertisement for the sedative drug phenobarbital, a type of barbiturate, clearly emphasizing its sedative properties. And when drugs that we now refer to as antipsychotics were introduced in the 1950s, they were first used by psychiatrists in France, they were also initially regarded, according to this drug-centered model, as special sorts of sedatives. And indeed, they were referred to in the very early literature as neurological inhibitors, and then later as neuroleptics, something which has a very similar meaning, lepsis meaning to seize or restrict. And they were also referred to as major tranquilizers for a long time. This is an advertisement for one of these older antipsychotic drugs known as Mellaril. from 1960, which is clearly emphasizing its tranquilizing properties. And because they were recognized and understood as being tranquilizers, they were very widely marketed for other indications for which tranquilizers might be useful, such as agitated behavior in the elderly, and also behavior problems in children and anxiety in adults. But gradually, over the course of the 1960s, they came to be viewed more in line with the disease-centered model. They came to be seen as working in a more targeted or specific manner. And this is a quote from a prominent textbook of the time, which says that they appear to do more than just tranquilize. So by 1970, this is an advertisement for the same drug that was advertised here. And it's talking now about it having antipsychotic properties. And the advertisement has a target. It's a nice psychedelic target because it's 1970, but it's nevertheless a target. And the idea is that this drug is targeting the specific symptoms of psychosis or schizophrenia. And a very similar process happens with antidepressants. The first drugs that was suggested to be effective as antidepressants were actually stimulant substances that were being used in the treatment of tuberculosis. And in the early papers written about them, they were clearly described and recognized as being similar, having similar effects to amphetamine, including stopping people sleeping and maybe making people psychotic on occasion. By the 1960s, there are lots of statements like this. Antidepressants appear to act specifically against depressive symptoms, and they were increasingly distinguished from stimulants. And indeed, later antidepressants that came along were not stimulants. This is an advertisement for imipramine, the tricyclic antidepressant, emphasizing its specific thymoleptic, that means mood targeting properties. So I think you can see the change in thinking about psychiatric drugs most clearly when we look at how they are named and classified. So prior to the 1950s, drugs are understood and classified according to the sorts of alterations to normal mental activity that they produce, and they're crudely just classed into as sedatives or stimulants. From the 1950s onwards, they start to be named and classified according to the sort of disease they are thought to treat. And we now talk about antipsychotics, antidepressants, etc. And the important point to note is that this transformation does not happen because of accumulating evidence for the disease-centered model. There was and there is very little support for this model. The majority of evidence that we have to support the use of psychiatric drugs comes from placebo-controlled trials, and they do not distinguish between whether a drug is acting in a disease-centered or a drug-centered way. Other bits of evidence that we have that might support the disease-centered model, such as ideas about mental disorders being caused by abnormalities, underlying abnormalities of brain chemicals that might be corrected by drugs, have also not been substantiated. So the famous dopamine hypothesis of schizophrenia is thought to support the use of antipsychotics, many of which do, among other actions, block some types of dopamine receptors. But actually, it's been found that dopamine is not central to the action of all antipsychotics. This was a systematic review that was done recently and concluded that the blockade of dopamine D2 receptors is a contributing factor to the mechanism of action of some antipsychotics, but not all. The fact that stimulants induce psychosis has often been used as evidence to support the dopamine hypothesis, but that's also never been pinned down to dopamine. Measures of dopamine and dopamine receptors either show no difference between people with psychosis or show differences that have been shown to be induced by prior drug treatment. And other more indirect studies of dopamine activity such as uptake of L-DOPA, the precursor of dopamine, show inconsistent results and are confounded by stress, arousal, and movement. Dopamine is a chemical that is associated with arousal and released when people are under stress, when people are moving, when people are agitated, when people are concentrating hard on something, when people are cold, when people are hungry. None of these things have been satisfactorily controlled in these studies. And that's just to show you how varied the receptor profile of different antipsychotics really is. And the haloperidol and aripiprazole that look a bit similar work on the D2 receptor in completely different ways, so they're not even remotely the same either. What about the other famous neurochemical theory of mental disorders, the serotonin hypothesis of depression? I published a paper last summer, a systematic review, in which we looked at all the different areas of research on serotonin and depression. We included 17 meta-analyses that compiled evidence on all the original studies and some big genetic database studies. And basically we found that none of those areas showed consistent evidence that depression is associated with lower serotonin concentrations or activity. There was a little bit of evidence from some areas that it might be associated with higher serotonin levels and activity, but this evidence was inconsistent and weak, and the results were likely to be due to either just random false positive results or the consequences of taking antidepressants. There was some evidence that taking antidepressants is actually associated with lower serotonin from these studies. And the genetic studies that we looked at were, it's always difficult to prove a negative, but the genetic studies were very, very large and very convincingly negative. And also, it was very interesting that there was a stark contrast between the negative effect of the gene and very strong effects of adverse life events and stressors in these studies. So I just want to think a bit now about the implications of adopting a drug-centered model of drug action, what it means about what the drugs are doing to people, when they might be useful, when they might be harmful, and how we might approach treatment in general. And I'll just finish with just a couple of thoughts about coercive treatment, because I think you were talking about that later. So first of all, if we take a drug-centered model, the first thing we need to really think about is what sort of alterations do different sorts of psychiatric drugs produce? How do they alter normal mental activity and normal behavior? And for this, we really need studies that have been done in volunteers, or animal studies give us some indication of this. And the trouble is the volunteers studies that have been published provide very limited information on this sort of thing, because the field has basically been based on the assumption that drugs work according to a disease-centered model. No one has really thought it worthwhile to describe the sort of mental alterations that psychiatric drugs produce, astoundingly, really. We have a little bit of data on antipsychotics because, as I said earlier, when they were first introduced, the psychiatrists who used them and the people who were researching them did have a drug-centered model, and they did do volunteer studies in which they did document how these drugs were affecting people, how they changed normal mental activity, and they did animal studies as well, which they reported in this way. And these studies show that these drugs basically are, as we would expect from sedative substances, drugs that reduce movement and most cognitive functions, including attention, reaction times, coordination, memory, etc. They reduce spontaneous activity, and the subjective effects that people describe are that they feel sedating, but also importantly that they feel they seem to have emotional flattening or blunting effects. They cause emotional indifference and reduce people's initiative. So people in one very interesting volunteer study, people who'd taken an antipsychotic drug, a bit like haloperidol, described how they could do things if they were told what to do, but having to work out what to do themselves was really difficult. And one man described how he couldn't even use a sandwich machine to buy a sandwich. And comments by patients who've taken them for various psychiatric disorders really reinforce these effects. People describe them as causing feelings of mental and physical stagnance, causing them to feel emotionally empty. I should say at this point that, as I hinted earlier, antipsychotics are a diverse collection of substances. So the profile of effects induced by each one is a bit different. So I'm not suggesting that they're all the same, but they do all seem to be associated with this emotional blunting effect. And this is Pierre Dennecker, who was one of those French psychiatrists who first used antipsychotics. And he proposed that they worked basically by inducing a mild form of Parkinson's disease. And that Parkinson's disease is a disease that attacks the part of the nervous system, particularly the part of the nervous system that produces dopamine, and people become slowed up, both physically and mentally. And they either become depressed or emotionally indifferent. And he felt this property of emotional suppression was key to their impact on psychotic symptoms, and described how people with psychotic symptoms simply lost interest in their delusions. This is a description by him and his colleague of the sort of effects that were characteristic of these drugs, and he describes it as the apparent indifference or delay in response to external stimuli, the emotional and affective neutrality, the decrease in both initiative and preoccupation, but without alteration of awareness or intellectual faculties. I think that's debatable. I think subsequent evidence would suggest there is some reduction of arousal and impairment of cognitive faculties, but he's comparing the drugs at this point to the older barbiturate drugs that were in use at that time, which probably had more profound effects of that sort. And this is just another quote from that time, talking about how there's no line of demarcation between therapeutic degrees of reduced psychomotor activity and early symptoms of Parkinsonism. In other words, the property of these drugs to be able to slow people down both physically and mentally was the therapeutic effect that people were using them to achieve. This is a much more recent study from the US that just reaffirms, I think, this view of what antipsychotics are doing. This study looked at the sorts of changes that were occurring after 6 weeks of antipsychotic treatment in people who had an acute psychotic episode. And what it showed was that the greatest change occurred in people's behavior, and the second greatest in people's emotional involvement with their symptoms and preoccupation. And people's actual level of conviction and their external perspective or insight were much less likely to be altered. I think this quote from a website, from a pharmaceutical website, sums it up well. This is someone who was taking an antipsychotic for a psychotic episode, and she said, "Although I felt very well, I felt as though I had absolutely nothing to talk about. I kept wondering whatever it was that had been so interesting during most of my life that I had suddenly lost. But I was very much in contact with reality, and for that I was thankful." This is a cartoon by someone who calls herself Auntie Psychiatry, which I think captures that dilemma expressed in the last quotation very well as well, that there is a toss-up for people sometimes between the dangerous but sometimes enticing world of psychosis and the what Oliver Sacks's brother called rottenly normal state induced by antipsychotics. So given that those are the effects of antipsychotics, what would a drug-centered approach to the treatment of psychosis look like in relation to the use of antipsychotics? Well, The immediate effects of antipsychotics may be useful if someone is deeply preoccupied by psychotic symptoms. The antipsychotics may, through this process of emotional numbing, help people to distance themselves from the symptoms, so they're not so preoccupied. But we have to keep in mind that these drugs are intensely disliked by many people, and also that some people can get through a psychotic episode without drug treatment, or maybe having minimal drug treatment occasionally. So that's just to show you the effects of acute treatment. So a colleague of mine, Ruth Cooper, recently did a systematic review of minimal medication approaches, including the Soteria project run in San Francisco in the 1970s. And she showed that some of these projects were showing quite good outcomes, as good as the outcomes that are achieved generally by treating people with standard protocols using antipsychotics. And there's been a recent pilot trial conducted in Australia, which was actually a randomized controlled trial comparing placebo with standard antipsychotic treatment. And that trial found that there was no difference in their primary outcome, that was social functioning at six months, between the placebo and the antipsychotic group. But it should be noted that this was, everyone received very intensive and high quality psychosocial care in this particular study, so may not apply in a different context. What about long-term treatment? I think it's obvious, if you think about the sort of alterations produced by antipsychotics, that long-term treatment may not have such a good cost-benefit ratio. What's the evidence base for long-term treatment? Why is it that we give most people who have psychotic episodes long-term treatment that usually lasts for years and years, and often for people's whole lives? Well, it's based on numerous randomized controlled trials comparing antipsychotics and placebo. But the first thing to note is that these trials are not trials of starting antipsychotics and starting the placebo. They're trials that take people who are already established on antipsychotics and take half of them off and put them on placebo. And when you do that, you can show that the antipsychotic discontinuation strategy produces relapse more frequently than continuing people on antipsychotic medication. And there's also a difference in rates of hospitalization. But as I said, the problem is these are discontinuation studies. That doesn't necessarily mean that starting the long-term treatment in the first place is beneficial. And that's because we know that stopping long-term treatment with most classes of drugs can result in adverse effects that we often might refer to as withdrawal effects. So there are immediate withdrawal effects of antipsychotics, which may include agitation, may sometimes include psychotic symptoms. And there is also evidence that stopping antipsychotics increases the risk of having a relapse of the underlying psychotic episode. The other problem with these studies is most of them have been short-term, and there's little data on outcomes other than relapse. There have been a number of long-term follow-ups of cohorts, uncontrolled cohorts without a placebo group or any other comparison group, which have all suggested that people who take long-term antipsychotic treatment do worse than people in the long term than people who don't take it, or at least don't take it regularly. This is the Harrow study conducted in Chicago, just showing how the percentage of people in recovery from schizophrenia was much higher in people not taking antipsychotics. And this is an interesting study from Norway, where they showed that, see if my cursor works, there we are. They showed, we're just looking at the top box here, people who were not on antipsychotics and had remitted did better in terms of their social functioning than people who had a remission but were on antipsychotics. And they both did better than people who had not had a remission. The problem, though, with these studies is, of course, that people who manage to avoid taking antipsychotics are likely to be people who have less severe conditions in general. So evidence from randomized controlled trials is really important. This is evidence from a randomized controlled trial of people with a first episode of psychosis that did a 7-year follow-up and showed that people who had had the reduction treatment, that's DR, drug reduction, were much more likely to be in recovery, 40%, versus people who had had maintenance treatment, that's 17.6% of them were in recovery. It's in terms of symptoms, they were doing about the same, but their recovery was based on their levels of social functioning. And the other thing that was interesting from this trial is you see this discontinuation effect here. Although early on, the people who were randomized to reduction were more likely, sorry, it's the black line, more likely to relapse. As time went by, this point's about 3 years, their relapse rates equalized with those who were randomized to the maintenance group. This is a randomized controlled trial that reported slightly different findings. It did a 10-year follow-up. It was a placebo-controlled trial, a very short-term placebo-controlled trial. The authors here claimed to find that their composite outcome of treatment failure was higher in people who had been randomized to placebo than people who hadn't, but there were all sorts of problems with their analysis, and basically they don't find any difference in symptoms or social functioning at 10 years, at the 10-year follow-up. We know, of course, that antipsychotics are associated with lots of very dangerous consequences on occasion. They're associated with sudden cardiac death. They cause weight gain. They cause diabetes. They're associated with sexual dysfunction, which most takers find extremely distressing. And recent evidence suggests that they are associated with brain volume reduction. This evidence is now coming from a whole range of different studies, and there's fairly good consensus now. I think it's accepted that this happens. The most robust evidence is this evidence from 2 animal studies, one in macaque monkeys, one in rats, both showing that antipsychotic treatment caused around about a 10% decrease in brain volume. After 18 months in the monkey study, which I was told would be the equivalent of 5 to 6 years in human terms. So Robin Murray, who's a prominent psychiatrist in the UK, wrote this editorial in World Psychiatry in 2018, in which he put together some of this evidence and basically suggested that what we need is a much more subtle use of prophylactic antipsychotics. A much more selective use might have been another way of putting that. And that's and a number of studies looking at the effects of antipsychotic reduction after a first episode or multiple episodes of psychosis have been conducted and are being conducted, including one I'm running in the UK called the Radar trial, and these other ones that are ongoing. So I just wanted to have a think about how these ideas might apply to bipolar disorder. And the first thing to say about bipolar disorder is that it has become a very slippery concept, and often it's not clear what it refers to anymore. It used to be called manic depression, and that used to refer to a very severe condition in which people had manic episodes that almost invariably ended up in admission to hospital, where their behavior became extremely disturbed. But over the decades, and partly because of pharmaceutical industry incentives, the concept has been expanded into bipolar 2 and then bipolar spectrum disorder, and then this whole concept of mood instability and pediatric bipolar disorder. And it's really not clear that any of these concepts actually have a relationship with the original concept of manic depression. And as I said, they've got more and more common. So manic depression is a rare disorder that affects less than 1 in 1,000 people. But subsequent estimates have suggested it's more common, that bipolar 1 is more common, and that up to 24% of the population may have something on the bipolar spectrum. The internet has lots of these self-rating symptom tests, which include symptoms that most people would say yes to. Does your self-confidence range from great self-doubt to equally great overconfidence? Are there great variations in the quantity and quality of work you produce, etc.? And this idea of bipolar disorder consisting of mood swings has also been reinforced by the pharmaceutical industry in advertisements such as this one. So the important thing is, what are the drugs doing that we prescribe for people with bipolar disorder? And I think this is an area where many people are confused. There really is no such thing as a mood stabilizer. This was a concept that was invented by Abbott Laboratories to market their anti-epileptic drug Depakote to people with psychiatric problems in the 1990s. All the drugs that are referred to as mood stabilizers are essentially sedative agents of one sort or another. There have been some volunteer studies with lithium that show that it actually doesn't reduce mood fluctuations, and there's been no similar research on other mood stabilizers. What the evidence base for the use of these drugs consists of studies that show that continuation treatment with one of these drugs reduces the risk of relapse, mostly relapse into mania, compared to discontinuation. And almost all of these studies have been done with people with classic manic depression or bipolar 1. Now, it may be that these sedative substances do have a protective effect against having a manic episode. Mania, after all, is characterized by over-arousal. But there is also a very prominent discontinuation effect, which you can see illustrated in data from this trial, which was a trial comparing olanzapine and placebo for prophylaxis of acute mania. And you can see that what happens is the placebo group have a much steeper relapse rate in the early days of treatment. And then the relapse rates even up. And it's actually been shown for lithium that the risk of relapse after stopping lithium is higher than it was before starting it. There are 3 studies that show that. And the other thing that's important to note is there's almost no research in people who have other types of bipolar disorder. So the question is really, I think, is the possible, or to summarize how we should approach treatment of bipolar disorder, I think this is how we should look at it, is the possible benefit of taking a sedative substance in reducing the risk of relapse slightly, not completely. The possible and unproven benefit, does it outweigh the negative effects, the adverse effects that people will experience? And some people might, some people have really very scary manic episodes and might take the chance, even though it's not really been proven, that going on some of this treatment might reduce their risk of having a recurrence. Other people will not want to take that risk. But I'm concerned that people are not given that clear choice because they're told that the mood stabilizer is somehow rectifying some abnormality in their brain, and they therefore need to take it. So I'll just say a couple of words about antidepressants, and then I will finish up. So what does a drug-centered model of antidepressant action look like? Well, as I said before, first of all, we need to think about what sort of mental and behavioral alterations drugs that we call antidepressants produce. Antidepressants are even more diverse than antipsychotics. You've got tricyclic antidepressants that are related to antipsychotics and that are profoundly sedating. Then you've got SSRIs that are seem to be a little bit activating in some people, but not in a pleasant way. And then you've got a collection of other drugs that have been marketed as antidepressants that have a variety of other sorts of effects. The data from volunteer studies in tricyclics shows that they cause sedation, cognitive impairment, and they're unpleasant to take. They cause dysphoria. There's really no equivalent evidence for SSRIs, but if you look at what people who are taking them for mental health problems or other problems indeed say about the sort of alterations they experience, I think you can say that they're generally more subtle than alterations produced by tricyclics or antipsychotics, but they do seem to induce this state of emotional numbness. And that seems to be associated with their well-recognized ability to interfere with sexual functioning and cause reduced libido, among other problems. They generally seem to cause lethargy, especially with long-term use. And in younger people in particular, they sometimes produce these, what I referred to as activation effects earlier, which seem to consist of agitation and is possibly associated with suicidal impulses and aggression. And they seem to be fairly neutral in terms of their effects at lower doses, but at higher doses, volunteers report them as being unpleasant to take. What a drug-centered model really asks is, are those effects useful? Of course, there will be an interaction of these effects with the symptoms that someone is experiencing. That may lead to a lessening or obscuring of symptoms. For example, the emotional numbness people get from antidepressants may reduce the intensity of their negative emotions, as well as reducing the intensity of positive emotions. We also need to bear in mind, though, that they have placebo and amplified placebo effects that contribute to their effects. So the question really is, are these effects useful? And my answer to that is that the evidence really doesn't support the fact that they're useful. It shows that the difference between antidepressants and placebo is extremely small, around 2 points on the Hamilton rating scale for depression. The Hamilton rating scale has a total of 53 points. Baseline treatment, baseline scores are usually, that's the green column, are usually around 30. And the difference between drugs and placebo is this much, the difference between the blue and the red column. The average difference between antidepressants and placebo in a recent meta-analysis was even less, at 1.75 points. And various forms of evidence suggest that really this difference is clinically irrelevant. This particular study suggested you'd need a change of about 8 points to show a minimal level of improvement as rated on the Clinical Global Improvement Scale. And as I suggested, unblinding and amplified placebo effects may have a prominent impact. So people can often guess. People in placebo-controlled trials can frequently guess whether they're taking the antidepressant or the placebo. And this randomized controlled trial showed that this was a negative trial. There was no difference between the actual treatments. That's the real difference, the drug allocated bars. The drug guessed bars shows that, however, when you analyze the results according to what people guessed they were on, rather than what they were actually taking, there was a statistically significant and substantial, much more substantial difference between placebo and the two active drugs. Antidepressants have, I would say, less frequent and immediately debilitating effects compared to antipsychotics, but they are associated with some very problematic effects for some people, particularly when people are using them for long periods of time, including withdrawal effects that may be severe and prolonged, and sexual side effects, which may be, as I mentioned earlier, persistent. This is, I think, a really huge and significant problem because many young people are starting on these tablets, and we don't know how prevalent this condition is, but it is being reported more and more frequently and has been picked up in the sexual health sector as well as now starting to be acknowledged a bit in the mental health sector. Okay, so just wanted to conclude with some thoughts about the implications of this for coercive treatment, and then I'll stop and we can have some discussion. So the disease-centered model is suggesting that drugs reverse or ameliorate an unwanted biological process that is giving rise to symptoms, a disease. And so according to this model, you can justify forced drug treatment because most people agree that treating a disease is a good thing to do, and also that a brain disease can affect people's judgment, as is the case when people develop a brain tumor or multiple sclerosis or other forms of brain disease. The drug-centered model has really different implications, though, because it's highlighting that psychoactive drugs can change people's usual selves, change people's emotional lives, change people's behavior. So they're really changing people's character to varying extents. And this means that forced treatment, that's treatment that other people want, but the person themselves doesn't want, means that other people prefer the drug-induced state to the individual's previous behavior. And when treatment is given on a long-term basis in this way, I really think that it can be thought of and should be thought of as character modification using drugs. And I'm not necessarily saying that that is always wrong, but I am saying that we need to think about it very, very seriously and have more safeguards than we currently have. In the UK at the moment, we have community treatment orders, which means you can essentially, on the say-so of one psychiatrist, force someone to take an antipsychotic drug or another drug for the whole of their lives. And they're very rarely overturned by the tribunal system. In my view, that's a very profound infringement of people's human rights. Why are these issues important? I just wanted to finish on this quote from someone called Peter Westcott, who published a little piece about his experience of psychosis and treatment in the British Medical Journal in 1979. He was someone who was being treated with a depot injection of antipsychotics. And he said, "Unfortunately, my personality has been so stifled that I sometimes think that the richness of my pre-injection days, even with brief outbursts of madness, is preferable to the numbed cabbage that I have become. I am advised by all my doctors to continue with my injections and will do so. But in losing my periods of madness, I have had to pay with my soul, and the price of health seems twice as high as Everest." So, thank you very much. I will stop sharing now. I'm happy to take some questions.
Thank you so much, Dr. Moncrieff. What a thought-provoking presentation, and I know we're all honored that you're here talking with us today. I do have one question that popped up in the chat from Sarah Hancock, one of our virtual attendees. She says, "Dr. Moncrieff, thank you so much for your tireless efforts to help people understand the role that psychiatric medication can play in the long-term consequences typically wrongly associated with treatment resistance. Could you please touch on why equating psychotropic medication with giving insulin to treat diabetes is a dangerous, misleading analogy?"
Yes, absolutely. So this diabetes is the model that is often used to explain the disease-centered model of drug action. So, in diabetes, insulin is necessary to replace the body's underlying failing insulin supply, to replace a deficiency that has been produced by a biological abnormality in the body, that is the failure of the pancreas. And people need to stay on the insulin for life because the pancreas doesn't start working again. There has been no underlying abnormality of that sort found in people with psychosis or schizophrenia or depression or any other mental disorder. So that's the first reason why it's completely misleading. And it's misleading because, of course, if you're told that you have an underlying defect and the drug is going to put it right, it sounds like a very sensible thing to take the drug. In fact, you'd be either irresponsible or you'd have to have a really good reason not to take it in that situation. But if you acknowledge that we don't have any evidence of a biological abnormality, and the drug is actually changing the normal state of the body, that immediately changes the situation and changes your considerations. And to take a substance that that changes the normal state of the brain, in particular for long periods of time, is a hazardous thing to do. And telling people that this is like insulin for diabetes covers over that, so that people are not aware of the fact that they're doing something very hazardous and that they need to think about it, you know, very, very carefully.
Thank you.
So yeah, thank you.
Yes, thanks for your question, Sarah. And then we had a question about your references. So I just want to let everyone know that on your attendee dashboard, you can access all of the conference materials, including Dr. Moncrieff's presentation, which has her references listed on there. So, and then David, I don't know if you have any questions in the room there for Dr. Moncrieff.
Yeah, we do have some questions. Can you hear us okay, Dr. Moncrieff?
Yes, yes, just about, yeah.
We have some questions.
Very quiet.
Hi, Dr. Moncrieff. This is Jim Mooney. I work as a primary care physician in the community internationally. So I actually have a couple-part question. One is, does the United States behave differently than the rest of the world in the context of like psychopharmacology or using medications primarily?
Okay, yes, really good question. Do you want to answer your next question, or shall I answer?
And the next part would be, is there, you know, what alternative model should we be proposing? Because as a primary care provider, I see patients using all of these drugs that you mentioned for various things, mood disorders, for the elderly, for sleep, or just, you know, brief episodes of grief, you know. So it's the prevalence of these drugs that's getting phenomenal. And I do inpatient medicine as well. So what's an alternative model if we are behaving differently?
So first of all, yes, I think in the US is slightly different from the rest of the world, and the UK may well also be at the opposite pole because of our national health system. There is no incentive in the UK to overtreat, and there's an incentive to undertreat because the services are so stretched. And there's been a limited list of drugs that can be prescribed on the National Health Service for a long time. So it's much less common to see people on multiple sorts of different psychotropic medications in this country. And I get the impression that in the US, as you said, people are often on numerous different things, often some that have been started to counteract the side effects of other ones. And sometimes this relates back a bit to the previous question, you know, sometimes when someone hasn't got better on an antidepressant, then they're given another diagnosis and another drug, you know, well, maybe it's bipolar and we'll put you on a mood stabilizer as well. A little bit of that happens in the UK, but not that much. So I think the US is a bit out of step there. And you know, of course, you've had direct-to-consumer advertising, so I think you're a much more pharmaceutically saturated society than we are as well, although plenty of it gets over the channel on the internet and things. What's an alternative model? I mean, the alternative model is the drug-centered model. So, you know, acknowledging that these drugs are changing people's normal states of mind, normal behavior, that is an inherently hazardous and harmful thing to do, and we need to be careful with it. So I think as far as drugs are concerned, you know, the alternative model is really make sure the drug is absolutely essential and there is no alternative way of dealing with the problem. If you really do need to use it at as low a dose as possible for as short a time as possible, and then take people off it. And take people off it slowly, but the shorter time they've been on, the easier it will be for people to get off. If people have ended up on drugs for many years, they may need to come off very slowly. And alternative approaches to supporting people, I think, depend so much on the individual problem. So, you know, when I'm talking about depression, I would say depression is generally a normal reaction to things that have gone wrong in people's lives. People are not always able to identify what those are. So sometimes therapy can be helpful to enable people to identify them. We know people have different susceptibilities to depression, and people are more vulnerable if they've had stressful life events in their past and particularly in their childhood. So some therapy to help people deal with those issues or become more robust can be helpful, but also just practical help to help people sort out the problems that exist in their current lives is important. So that's how I'd talk about depression. With psychosis, it's a more unusual situation. It's often it can be associated with behavior that is challenging, sometimes even threatening. It can be scary for the person experiencing it as well as people around them. I think people with psychosis need help and support and sometimes containment and a safe space to be in. Now, one of the problems in the health service in the UK, I expect it's the same everywhere, is that we've reduced our bed base considerably. So people will go into hospital now, but only very briefly, and then there's a lot of pressure to get them out of hospital. What's the only way of getting someone out of hospital is highly distressed and disturbed. It's to drug them up to the eyeballs and send them out heavily sedated. And that is sometimes what's happening in this country. Whereas what would be nice to see is some of those experiments that I referred to briefly, like the Soteria project, where there was a facility where people could receive support and get through a psychotic episode without treatment, if possible. And that not everyone, I don't think, will be able to, but some people will be able to, and some people will want to. And I think just, non-intrusive social support is actually what's most helpful when someone's acutely psychotic. Thank you.
Hi, doctor. So I just want to make sure I'm understanding the way you were showing the slides, the antipsychotics and all that medication, then their relapse is higher when they're on the medication than when they're taking minimal amounts. Fairly simple-minded.
No, it's fine. So there are two. I showed you evidence from two sorts of studies. One sort of study is the randomized control trial that compares people who are taking, that takes a group of people who've been established on antipsychotics, for example, and then randomizes half of them to be taken off their antipsychotics and put on a placebo, normally overnight or over a period of a few days. So those are what we might call randomized discontinuation studies, and they find that people who are taken off antipsychotics have a higher rate of relapse, possibly due to discontinuation effects. Now, the other sort of study are studies that have just followed people up without randomizing them. So, and the problem with those studies, the reason you randomize people is to ensure that the groups of people who end up on the discontinuation and on the placebo and on the maintenance treatment are generally comparable. There's no systematic difference between them. That's what randomization ensures. So these other follow-up studies haven't used randomization. They've just compared people who have naturally decided to stay on long-term treatment or decided not to, or been made to stay on long-term treatment, for example. And those are the ones that find that the people who stay on long-term treatment do worse in the long term. But that is probably, I would say, probably mainly due to the fact that people who end up on long-term treatment are the people who are doing worst. They're the people who can't escape the system, basically. And the people who manage to get off are the people who do better. So it doesn't necessarily suggest that staying on long-term drugs makes you unwell. It suggests that being very unwell means you end up on long-term medication. But there may also be they tell us a couple of things, those studies. They tell us that if you can get off long-term treatment, you seem to do better than people who stay on long-term treatment. And that may just because you would do better anyway, but it may be something to do with the treatment itself. All that mental slowing that antipsychotics produce and cognitive impairment is not likely to be helpful to people. So if people can survive without the drugs, they're likely to be doing better. So I hope did that make it clear?
Yes.
She says yes. Yep. Another question in the room.
My understanding of the placebo effect is it's based on the disease-centered model. So when people are participating in these, there's a general belief that it is going to help. Hence the placebo, where you see some improvement without having taken the medication. Has there been research in situations where people are forcibly medicated and do not believe that the medication is going to actually help them? Because since the margin of the medication being effective and being helpful is already quite low, when you take away the belief that the medication is going to be helpful to yourself, does that then eliminate or make negligible the margin of actual help that can be given when medication is forced?
Great question. That's a really good point. I can't think of any studies that have been done of, placebo-controlled studies of forced medication in that way. I also can't think, what you could fairly easily do, couldn't you, is ask people what their expectations are of treatment. There are 1 or 2 studies that have done that. I'm involved in analysing a study of antidepressants in children and in adolescents, actually, and they were asked for their beliefs prior to going into the trial, and I think their parents might have been 2, and I can't remember whether I don't think actually the beliefs did have a very strong impact on outcome, but what they guessed they were taking did. I think the problem with asking people their beliefs is, you're never quite sure whether you've completely tapped into their beliefs or not. And there are probably some other studies out there like that, which would be interesting to look at, because you're absolutely right. It's the placebo effect. The placebo effect is a number of different things. So the improvement that you see in people taking placebo is partly just the natural history of the condition. But it is also, I believe, and I think that graph I showed you, where people were, the outcomes of the antidepressant trial according to what people had guessed they were on, I think that shows you that there is a substantial additional placebo effect compared to the placebo effect that may just be the natural improvement that people experience. But yeah, really, really good point, and something that I think just hasn't been looked at properly or thoroughly enough.
Ashley, we have another question in the room, but I know you're also getting questions. Do you have one?
Yes, I do have another one. So this one says, the USA does not have public reporting of agency client outcomes, and in many cases have very little internal recording and reporting of client outcomes. Does the UK have reporting of client outcomes by agencies? And if so, are they public? And then the second part of that question, do you think that public reporting of client outcomes might help improve services?
Yeah, another good question. So we don't really have publication of outcomes. We have publication of things like bed days, how long people have been in hospital. You can get some prescription data. You can get suicide data and mortality data, but you can't get patient-rated outcomes. That's not sort of generally available. Some services do it, some individual services, but not generally. And yes, I think it would be a great idea. I suppose the question would be though, I think what an outcome is in mental health is a tricky question. I don't think it's really totally straightforward. Yes, we want to make our clients happier, but we could give them all opium and they might be happier. I suppose what we're really trying to help people to live more independent and fulfilling lives, and tapping into that, I think, is quite difficult. There are 1 or 2 questionnaires that have tried to. I think the recovery questionnaire, the questionnaire on the process of the recovery, I think it's called the QPR, is quite a good questionnaire that really tries to assess how empowered people feel, and how in control of their lives they feel, how much agency they feel they have. So I think that's quite a good one. But I think I think probably we need to do further work on outcome development.
Another question, Kate?
Thank you so much. I'm actually wondering if there is any, or your thoughts were, and if there is any additional research on what
I'm really sorry, I can't hear you. It's sort of, there's a bit of interference.
Drug, the long-term effects in your perspective of the numbing of the human experience. What does that look like longer term as we are increasing the dosing of our youth and everything else, and it changes their character? So what is going to be the long-term effects on the human experience?
The long-term effects of what on the human experience? I missed the beginning bit.
Because of the basically the overdosing, the drugging.
Okay.
Is there the long-term effects on the human experience, because it's feeling they're disconnected. So just, is there any studies, and what is your perspective?
Yeah, no, great point. I mean, in the UK at the moment, we've got about one in 6 people take an antidepressant. You've published recent figures in the US, and I can't remember what it is, but it's around about the same, if not a bit higher. And these are drugs that cause emotional blunting. So, great question. What are we doing to ourselves? What are we doing to our relationships, our interactions, our social life by having a large proportion of people on drugs that blunt emotional responses? Our emotions are there to enable us to assess and evaluate things that are happening around us and respond in a sensitive way. And if that's all blunted, we're going to be responding inadequately to other people's needs and to the needs of the environment. So I think it's really worrying in lots of ways. Another thing that really worries me is this question of agency, and that if people believe that their problems are coming from their brain and they need a drug to put it right, that's a profoundly disempowering message to have absorbed, and I think really sets people up to have chronic difficulties, and potentially be dependent long term on services and on other people. So I think that's really problematic. And then and then we're giving these drugs to children. We're giving that message to children as well. What does that do as you're developing your sense of self? There's been some really interesting work on children. Who is it? I can dig it out if you're really interested. So it's some qualitative work by a social scientist on the effects of taking antidepressants on young people's emerging sense of self, which explores some of these areas.
Maybe one more question in the room. Has there been any research done on people who have recovered from schizophrenia and have stopped medication completely?
There hasn't been much research into how they're getting on, what their lives are like, but there are a number of studies that document that people do recover from schizophrenia. One of them is the Chestnut Lodge study. So Chestnut Lodge was psychoanalytic community in the States. I don't know when it was set up, but it was running in the 60s and 70s. And a couple of quite biologically minded psychiatrists actually wrote up the outcome data from Chestnut Lodge and showed that, and I can't remember the proportion exactly, but a reasonable proportion of people from Chestnut Lodge, and they had schizophrenia or severe psychosis, had made a recovery without any medication. So there is research recording that happens. It would be terribly interesting, I think, to do some research on people who had a diagnosis and in the past moved on with their lives, see what they were doing, and that would be so inspiring for other people, wouldn't it? So I'll put that on my list, on my bucket list. Thank you. For anyone else who's interested, that's something to look at.
Thank you, Dr. Moncrieff. I think I want to be respectful to your time and everyone. So maybe one more online, Ashley, and I think we'll have to end it.
Okay, yeah, one more. Do you have an opinion on how much liability influences doctors in overprescribing these drugs in America?
I can't give you an opinion in America, but I can tell you my experience in the UK, and I think liability is hugely influential. And for some reason, I mean, as I said, I work in the mental health services. I have to attend inquests and things. For some reason, lawyers think that not prescribing drugs is more makes you more liable than prescribing them. So every tiny reduction of medication you make in someone can potentially be scrutinized and be used against you if that person goes on to tragically take their own life or harm someone else. And so I think doctors are very wary. And when I was doing recruiting for the radar trial, it was a major stumbling block that doctors didn't want to put people into the study because they were so nervous about people having their medication reduced, particularly antipsychotics. I think probably people are a little bit less wary about other medications, but I mean, I've still had the experience of being scrutinized and challenged and questioned and given a really hard time about, very slightly reducing someone's antidepressants.
Well,
So
I think we probably need to finish, Dr. Moncrieff, just to stay on track, but I just wanted to thank you, and maybe we can all thank Dr. Moncrieff for her time.
very much. I hope you have a great conference, and it's been a pleasure.
Have a good rest of your evening over there, Dr. Moncrieff.
Sorry?
Have a good rest of your evening over there.
Thank you. Thanks very much. Thank you.
All right, bye.
Thank you. Bye, everyone.
Give us 5 minutes. Our next speaker, Mr. Whitepond, we'll have to switch a few things over, so take a comfort break. I did tell you restrooms are right across the hall on that window, so it's 5.